So without wasting much time, we will proceed with the case discussion. Now the topic which is given to me is like, being a surgeon, it comes with a pinch of salt that now we have to put this kind of case in a multidisciplinary tumor board, and where we have to advocate a radiation therapy. So I think, but it's good that we have all the facilities available and we have esteemed panel to guide us through the case. This is a live case, and before we start a discussion of oligometastasis, three definitions we need to be aware of. What is oligometastatic, what is oligorecurrence, and what is oligoprogressive? Because these three terminologies are like a new terminologies flaring up in RCC, where the management changes if we identify the correct stage, and we delay the progression to the advanced metastatic disease. So this is a definition where oligometastasis means less than 5 mets, and they have not yet reached the full aggressiveness to become a frank advanced metastatic disease. It can be synchronous or metachronous. Another one is oligorecurrent, where there are limited number of recurrent mets, but the primary tumor is well controlled and they are potential candidate for local therapy. And third is oligoprogression, where the patient has a metastatic disease, but not all sites progress. There are few sites which are between 3 to 5 progress, and rest of the lesions remain static on the systemic therapy. So these three definitions are very much important. So this is our case where we have a young male, reasonably built, comes in the OPD with 2 months of back pain on the right side, 1 episode of hematuria, after that it settled, with no significant family or past history. And on examination, there is a lump in the right lumbar region, and patient's performance status is good since he is very young. The investigations were done, which are absolutely normal. And so I will just like to take a poll now, that how many of us should do what kind of imaging. I'll start with the panelists, and side by side you can do the polling also. So Dr. Shivde, please
I'll
suggest.
start with a screening ultrasound.
Okay. So ultrasound, Dr. Shivde is suggesting. Dr. Narayan?
Start will be with the basic investigation.
Okay. So we can have the next panelist, please. Dr. Roy? Do you agree with the basic thing, ultrasound, or you want something superior?
As long as I could get a good representative biopsy, I'm not really bothered about which modality.
Okay, so you have to wait for your turn then. And Dr. Datta?
I think we can do a screening ultrasound, but ultimately we do a FDG.
So here I have a difference of opinion, but I'll just share it with you. Can we have the poll results? Poll results are there. So majority are going with contrast CT. Yeah. So I agree with the mass that see, patient has a hematuria history. So definitely we have to rule out with a lump in the abdomen. So we have to be a bit more aggressive, thinking in the times of lines of malignancy. So we did an CT scan, and this was the lesion. So here you can see the right kidney having a big lesion, and rest of the things appear unremarkable. Liver normal, chest was normal, and the findings were almost 8.4 into 5.6 into 6 centimeter lesion in the right kidney, which is compressing the calyceal system. So that can be cause for hematuria. So this gives us a clinical staging. Another important thing were the small perinephric, aortocaval, para-aortic and paracaval lymph nodes. Now you see the diameter, they are almost sub-centimeter diameter. So I would like to ask the panelists, would you like to give some importance to these nodes, or can be a reactive thing, or maybe because he has a history of hematuria, maybe some kind of perinephric infection. So please, Dr. Shivdu.
In a scenario where you have a large mass, I would consider these to be significant and would address them at the time of surgery.
Great. Dr. Datta?
Yes, if it is more than 1 centimeter, then definitely we will think of disease.
Dr. Narayan?
Yeah, I agree with both the panelists.
Okay. So, for further evaluation of the lesion, FDG PET scan was also done. So how many of us agree whether the PET scan is a good imaging for RCC? Dr. Shivde, would you agree?
I think it's a good imaging for RCC.
Okay. And Dr. Datta, do you also think?
We need to do it because if you want to do a surgery, you have to do a metastatic workup, and PET scan may be useful.
Okay, great. So this was the finding for FDG, where we had the kidney tumor which is having a SUV of 6. The lymph nodes had a SUV of 2. And there were some mesenteric lymph nodes also, which were having SUV of 1.5. And mediastinal nodes also, SUV of 1.3. So what do you think? Is this a metastatic disease or it's some inflammatory or reactive etiology? Because now further line of management will be decided based on this finding. So Dr. Shivde?
I'll consider them metastatic unless proved otherwise, and nothing short of a good histology would prove that.
Okay. Do all the panelists agree with this?
See, the problem with PET scan is that if the renal mass is SUV6 and less than 40% in other areas, very difficult to convey.
So that was my first question. How many of us agree with the PET scan report? Because is it a good modality for RCC, especially when we are treating the case upfront? Recurrence, relapse, secondary thing. But whenever the RCC is intact, is it a good modality? So in this case scenario, we see mediastinal nodes, mesenteric lymph nodes, which we hardly encounter with RCC.
Yes.
So this is the crux of having a PET scan along with the CT scan, where we might be misguided. So anyway, further imaging was done just to rule out whether the patient has a chest nodes or not, and it was absolutely normal. So this was our diagnosis: right renal mass, most probably, and query lymph node involvement. So what are the options for us now? So these are the things. What the poll question comes, what is the audience thinking about the options for this patient? Dr. Shivde, we will start with you.
I will consider radical nephrectomy with perihilar lymph node dissection, possibly extending to the demonstrated positive nodes.
Okay,
because you got
great.
an FDG showing suspicious nodes.
Okay, so everyone is of opinion of having a surgery. Dr. Datta,
Yeah, surgery.
surgery.
Yes.
Your RT is having
No,
quite a
it's
role,
not.
right?
See, we don't manufacture treatment. We do the treatment which is required for the patients. For this patient, surgery is important.
So any evidence is there? Suppose I am thinking of it as a metastatic disease, and this patient having presumably good performance status. So is there a role for any stereotactic or local radiation?
See, there is some data.
Sir, mic.
There is some data on SBRT in RCC, upfront SBRT,
Okay.
because when you do a higher dose of fractions, more than 15 gray per fractions, there is a response, and the TKIs actually work better after the SBRT because of the abscopal effect which SBRT initiates. Sometimes when someone is having a bilateral RCCs, one kidney surgery is done there, another kidney upper pole there is a mass and difficult to do surgery. In that case, SBRT is an option.
Okay.
But not upfront. In one kidney is intact and other kidney upper pole, there is a mass which easily surgery can be done. Surgery should be the first option.
Okay. So, Dr. Narayan, are you agreeing for surgery, or you are of some?
No, I would go with surgery. First of all, this needs a detailed evaluation by a radiologist has to comment actually. Are we going with a suggestion that the mediastinal lymph node with an SUV of 2 is a metastatic node or not?
Exactly.
Right. So if I would go with surgery in this patient.
So it's unanimous that we are going with surgery, and the
If I
poll
can
also.
put in a comment that you don't have an option of an FNA confirmation. Would you not try it? It's very easy procedure, and it's very easy to confirm a metastasis on FNA.
So, Madam, the only problem here is they are all sub-centimeter nodes. So to target them would be quite a challenge. And when we plan to do a radical nephrectomy, I think we have a sufficient packet So we can take that all paracable nodes and maybe an inter-aortic cable nodes also and send it for the checking. So surgery was done and the specimen removed and the perihilar lymph nodes also removed. And this is the finding. So now I would like to have opinion from Dr. Roy. Is this report sufficient or you are now keen to investigate this patient a bit more?
So it's, I would have, I'm guessing on morphology, I don't have a morphologic image here of the microscopic picture. So, so we have the type given, which is papillary RCC, and the stage is provided. So high-grade areas, no sarcomatoid, I'm assuming no rhabdoid areas either. That looks comprehensive. Now looking at the IHC profile, it's CK positive, CD10 positive, Amaker positive, CK7 negative. It's kind of consistent with papillary RCC. We would have liked to add a CA9, which is positive in clear cells and negative in papillary RCCs. But there is, the classification of renal cancers is changing every day. There is no end to how much you can add a lot more IHCs because there are mimics of papillary type 2 RCC that we know of. But usually if it's a standard, regular morphology, we would do a similar thing. And so I'm happy with the report.
Sure. So now the question comes, what will be the protocol for papillary RCC? So Dr. Shivde, how will you follow up this patient? Now we have a type 2 papillary RCC.
I'll consider this to be more aggressive than a standardized RCC. Therefore, he will have 4 follow-ups in the first year.
Okay.
And I will probably do a 6-monthly CT scan of the chest and abdomen.
Any difference of opinion? Or everybody follows the same thing?
Follow-up will be the same.
Okay.
And if the baseline scan was a PET, I would do a PET actually.
Sure. And how will you follow up the contrast CT scan or you will require an FDG PET scan?
I would choose to do a PET scan since we have already done a PET scan. So it's easy to follow up the lymph nodal lesions, if at all, like for like comparison.
Sure. So I think this patient, PET scan was done, surgery was in September, so almost 4 to 5 months later on we did a PET scan. And the report was that there was no uptake in the operated area, there was no local regional lymphadenopathy, but there were few mesenteric lymph nodes, which were, and few retroperitoneal nodes, which SUV of 2.5, and common iliac nodes with SUV of 1.74. No mediastinal, hilar or axillary lymph nodopathy. So now again the question, okay, what SUV is good enough to categorize this as a malignancy? So our panelists, can you just throw some light? Now what we should do? Should we like go aggressive about this thing, or we have some time to wait and watch and observe? So I'll start with Dr. Narayan. What do you like to do in this scenario?
What is the comparison with baseline on this SUV? Is
Sorry,
it the same? The comparison with the baseline is the same, is it?
Yeah, almost the same. Almost the
If
same.
it is almost the same, I would not do anything for this.
Because the SUV is also the same.
Right.
2 and 1.2.
Yeah.
Dr. Datta, same opinion?
See, we will compare with the baseline because that is if you do a PET scan before the surgery, and that is considered the baseline, and from there any structural changes, when CT scan changes and PET scan showing uptake, there is change, then only we'll consider as disease. Otherwise, we will not consider as a disease.
Sure. So the panelists are of opinion that we will observe this patient. So okay, we agreed to that and then we observed it. So in August, we find something else. So again, there is no local regional lymphadenopathy. The retroperitoneal nodes now have increased in size up to 2 centimeters with a SUV of 14. Previously it was 2.5. And there are some additional aortocaval nodes of the size almost 2 centimeters with a SUV of 13. And common iliac nodes again have some low metabolic activity. So now what? Like we followed the protocol, and now we have end up with a disease which is having a retroperitoneal lymph node spread. So what is the definite investigation which will help us to rule out this? So Dr. Subodh, please suggest now what we should do for this patient.
I should have guessed कि दाल में कुछ काला है. Dr. Gandhi present कर रहे हैं. I think I will go for a CT guided biopsy of those nodes to know what it is.
Okay. Dr. Narayan?
Yeah.
Okay.
Biopsy.
Dr. Datta?
See, if radiologically it is showing there is a definitive change in the structure, and PET scan is showing uptake, I don't know that whether PET scan, any biopsy which may have a yield negative, because sometimes it is so difficult to do a biopsy from there.
Correct.
And it can give if it is inconclusive, you are back to square, and that happens in 70% of this kind of cases if you want to do that. So we will actually take the radiological pictures and treat accordingly.
Sir, can you just pick up in the mic because it's not audible? Turn on, please.
We will take a radiological picture and then treat accordingly, because FNAC many times can be inconclusive in this. It is not that easy to do FNAC in that.
So I'll just
Add a comment. It's a 2.7 centimeter lymph node, right?
Yes, yes.
Yeah. So failure rate is not 70%. No. It's FNAC or biopsy in this situation is quite a good modality, at least in my experience.
Yeah, we are doing a PET, and not only PET scan or SUV value, we are seeing the radiological picture as well.
Exactly.
If the architecture of the nodes has changed, it has increased in size, and it is not a regular structure, we know that it is disease, which actually is the SUV is showing uptake.
okay.
So FNAC is not going to give any addition. If there's a doubt, the size is not changing, or SUV is still in the range of 3 or 4, we will do a FNAC to find out.
Correct.
But if the SUV is 14 and radiologically it has increased in size, we are not going to get any additional information.
So you are of opinion we can directly proceed with the treatment for the loco-regional
Yes.
case and no biopsy. Sorry? So now you see, whenever we are contemplating any kind of intervention, what was the first histopathology? So that was a papillary type 2 RCC, which is very notorious, multifocal and multi-regional recurrences. So assuming that, okay, this may be the same histology, FNAC might not be an absolute necessity in this case.
Yeah.
Tuberculosis patient doesn't have a history. If we start suspecting,
See, anything can happen. Anything can happen. It can be anything.
See,
Sarcoidosis.
no. Correct. Okay. So we are coming to that point.
I totally second him for two reasons. You have to prove a recurrence. You just cannot assume on a radiology. You can suspect on it. Second, I would, as a medical oncologist, I'd like to do a molecular testing, and a biopsy would be very good to run few tests if it's papillary specifically. So no way in any case I think anyone should consider any local or systemic on such a case without a biopsy or FNAC whatever.
So please throw a light. Suppose keeping tuberculosis aside, what other pathology are you interested in knowing with the biopsy? Keeping tuberculosis aside.
I would like to run a few markers to do my targeted therapy, first of things. Second, how do I prove that it is a recurrence? And ideally in the first case when the PET scan came as a lower SUV, even at that time a discussion to the patient, because that time also the lymph node was 2 centimeters. And I agree with madam that
first time it was less than 2 SUV. It was sub-centimeter.
the size was around 2 centimeters.
Sub-centimeter.
Yeah, okay. So that is that, but I feel that it is not good legally, medico-legally, and even on the patient perspective to consider treatment to this patient without a tissue diagnosis.
Okay.
Very clear.
Okay. So what do you term this patient as? Oligometastatic, oligorecurrence, oligoprogressive, or an advanced metastatic disease? Like I gave you the definition. So can we have the polling? So here the primary operative site doesn't have any disease, and it is everything which is outside the surgical field. So Dr. Subodh.
So I mean, without the histology, you cannot label it as anything.
Okay.
So first of all, as the floor and us feel, we should biopsy. And then put it into some grading. So whoever polled have to take my opinion into consideration. I think you need to know the histology.
Okay, we agree.
See, now how many times we see histology is different in a metastatic setting? We don't. Getting someone who is having a SUV of 14 and radiological structures are showing there is a change, and have a history of RCC, there is a chance of nodal metastasis very high. So it has to be clinical judgment in most of the situations to find out. And how many times, I'll be 50% of the patients, if you do FNSC, you will land up in inconclusive. And neither you can do a IHC from there because you are doing an FNSC from there.
So all the guidelines, if we see, if the disease is resectable, then definitely direct surgery is an option. You don't require a biopsy to prove that, okay, it is a malignancy and so I am going in with the surgery. If the disease is resectable and it is curative metastectomy. So I think this is like absolutely, it's an oligo-recurrent disease, and that clears the doubt. And subsequently the patient was given the option and surgery was offered. And this was the lymph node packet which were removed, and that was the inter-aortic cable which was 2 centimeter and the paracable load which was removed. And 10 out of 11 lymph nodes were positive, and all the immunohistochemistry testing was done, which suggests the type 2 papillary RCC. So the histopathology has not changed. So this was exactly which was expected when we had a discussion regarding to do FNSE or directly proceed with a curative surgery. So this was done, and patient recovered well, everything fine. So based on this, do we have any evidence that we need to give something adjuvant to this patient?
Can I interrupt and go back to the previous slide?
Yes, sure, madam.
Just because the slide is being displayed for the audience, none of these markers are really specific for type, and in a metastatic setting we would just say positive for renal cell carcinoma. So CK, which is A1, A3, not CK7 used here. PAX8 just confirms renal origin, same with CD10 and AMACR. So use of this IHC is not very useful in this situation.
Correct. Would you like to do something else for this patient, madam? Like apart from
when
the
we
IHC?
have a known primary, we just compare with the primary and just say it's consistent with metastasis in a known case.
How about NSG panel or some other kind of the gene testing or something?
Upfront biomarker panel, no, we wouldn't do unless there is a test requested for it. And anyway, the PD-1 or PD-L1 assessment is debatable for kidney cancers.
Okay. So now we come back to Dr. Shivde. So now you have a patient operated, lymph node positive, operated again, and then lymph nodes are still positive. How will you proceed for this patient? What do you like to do now further for this patient? Any adjuvant therapy?
So I think this needs referral to the medical oncologist for adjuvant therapy. Certainly observation is not on my cards.
Okay.
I will give a guarded prognosis to the patient at this stage. It's the same disease that's recurred despite not having any evidence.
Sure. Dr. Narayan, the ball is in your court now.
Well, if it has been resected fully, there is no evidence to give adjuvant therapy at this point of time with the evidence that we have.
Correct. So the guideline says that after curative metastaectomy, there is no role for any adjuvant therapy.
Right,
Even
and to
though
come back to your question of what will you define it as, I think this patient always had this disease, right? Even though we were observing. So by the actual definition of a role of second surgery which we have done in this patient, it should be done only if the recurrence is after 1 year of the primary surgery.
Yes, so
if
the
I'm right.
time duration is
Right.
very much
So
important.
this patient actually is a high risk patient, and we are going to have a recurrence again for this patient.
Correct.
But there is no role to say that there is this level of evidence to give XYZ therapy at this point of time.
Okay. So if the patient comes to your clinic, how will you counsel? Because now he is very worried that, okay, now I have recurrence and there is a chance that within next 6 months I will have full recurrence. So how, what is the guidelines available?
We have to tell the patient that there is a chance of recurrence, but that does not mean that starting treatment now will give you this benefit.
We have a data. In that trial, there were M1 patients also.
Sir,
5%.
Sir, will you do PD-1 before you start pembrolizumab or EGFR?
As per the data, no.
So now this is a papillary type 2 RCC. Now adjuvant therapy as per the ESMO guidelines, there is no role after a curative metastectomy. So even if your lymph nodes are positive, what exactly Dr. Narayan told, there is no guidelines to start adjuvant, maybe a immuno checkpoint inhibitor or maybe a VEGF or TKI inhibitors and all. So he's absolutely true that the guidelines don't support the use. So how will you risk stratify this patient now? Is it, because now we know that this patient is a kind of a metastatic potential disease. So is it a poor, intermediate or favorable risk, Dr. Shivde?
I think risk stratification, if is recurred within 6 months with a nodal site, he is high risk.
Okay.
So I think you will have to spend a lot of time counseling him.
Okay.
If my medical oncologist is not offering him any upfront therapy by the books, he still should be told that you would have a very high risk of recurrence and possibly counsel him that he's got a limited lifespan.
Dr. Narayan?
Yeah, it comes, I mean, the risk stratification is very subjective, but in this case, since there was a recurrence immediately after surgery, this comes as a high risk, but that does not change the decision.
Okay. So if we see the IMDC criteria, he falls in an intermediate risk of metastatic potential. And madam, regarding young age, do you now suggest any workup for a hereditary linkage or something? Because he's just 30 years of age. So you have seen the biopsy report. So do you feel that now we should have some profiling for him? Dr. Roy?
No, I mean usually the young age presentation cancers which mimic papillary, like clear cell papillary, they're very good prognosis tumors. I wouldn't expect such wide metastasis. Collecting duct medullary, these cancers can behave poorly, but they would not mimic papillary morphology. But yes, but we can. So Bartók Dubé or VHL, I mean, I don't know the genetic screening, whether it would have any management implication for such an aggressive tumor. I don't think so, and there's no bilaterality here.
Dr. Datta?
Yeah.
Just a question, quick question. Would you like to radiate the operated field?
No.
No.
No, see, for this patient is young patient, 30-year-old, with a very short DFI. So we will actually look for if there is a von Hippel-Lindau disease there or not. Huh? So it has to clinically check up to see whether any other features of von Hippel-Lindau disease there or not, which actually sometimes associated with RCC. So young patient, short DFI, we will go for, we will just check. If there are other features, clinical features of von Hippel-Lindau, then the genetic testing for that will be done.
So, this patient, we did some checking and translocation was not detected. NSG panel for hereditary cancer, not there, it was normal, and VHL testing gene also normal. Again, we did a PET scan and it showed a progression of disease that was in right supraclavicular, retrocural, pre-aortic, aortocaval, retrocaval lymph nodes, no uptake in operative area, and viscerals were normal. So now what? Because he has again recurred, and this is like in almost 2 months, he has recurred.
We will start the patient on immunotherapy.
Now we will start a patient on immunotherapy. Okay. So what would be a drug of choice, sir?
If the patient can afford, then a combination of 2 immunotherapy drugs.
Okay. So in papillary type 2 RCC, you will start with either a Pembro or a Nivo?
Nivo plus ipilimumab if the patient can afford it. Yeah.
Okay. Fine. So this was the another question, like the answer you have already given. You will start with immunotherapy, and there is no role for radiation, correct, in this case now?
Yeah.
It's already a metastatic disease.
In kidney, there are few randomized data, very old data, which has shown there is no benefit of giving adjuvant radiations in there.
So this patient was started on this medicine. So patient was started on the cabozantinib, and he had some side effects, so it was stopped, and then subsequently he was started on sunitinib, and with this also he had grade 2 toxicity, so dose was reduced, and then subsequently again the CT scan was done, which showed that there is an increase in aortocaval load again, and then the drug was changed and he was started on immunotherapy, which now the thing is that the patient is on immunotherapy and there are few lesions which are increasing in size, rest is static, so this becomes an oligoprogression, and the guideline says that even the patient is on oligoprogression, you don't need to change the immunotherapy. So you can keep continuing the same therapy even though the patient is having an oligoprogression. So I think with this I would like to sum up, and thank you my panelists and the audience for patient listening.